First step that they come to is their consultation. And at the consultation, the first thing that we do is we usually take a pano and the doctor will see them. And usually all the doctor needs is going to be a mouth mirror and the panoramic x-ray. And there's a couple of different types of treatments that the doctor can recommend. The most general one and the most common one that we recommend is the full treatment. And that can be with or without extraction. And that can, on average, it's from 1.5 to 2 years. And then if patient has a lot of crowding and things like that, then the doctor would recommend extraction. And if a child comes earlier, around age 7 or 8, and they can start phase 1, and that helps with jaw development and to make sure that the upper and the lower jaw fit correctly. So for example, they can have something called a rapid palatal expander, which is the picture on the bottom left. And using that, they have a little key that they turn a little bit each time, and then that'll expand their upper palate. So their upper jaw will be larger. And then they'll get a break in the middle, and then they'll go to phase 2 treatment, which is, again, it's similar to the full treatment. They'll get full braces on the top and the lower. And this is to adjust the position of the teeth after the jaw is aligned. Another type of treatment that we do, but it's not very common, is the incognito braces, and those are the ones on the lower right, and those are the brackets that go on the lingual side. Those are usually not very recommended because they are more expensive. Only a couple people qualify to be eligible for that treatment, and it's harder for the patient to get used to because the tongue is so sensitive, and it's on the tongue side. Another case that we do is surgical, and this is to correct jaw irregularities. And the way this works is patient will come and see the orthodontist and have braces put on for a couple of months, anywhere from 6 to 12 months, and then after they would go to an oral surgeon and get jaw surgery. Before they get jaw surgery, the orthodontist is going to move their teeth, but it may seem worse than it did before because they're trying to prepare for after the jaw is properly set. And then after they get jaw surgery, they'll go back to braces for another 6 months to a year to correct the final changes. And the last thing that our orthodontist recommends, but he doesn't actually do, he refers them out to our general dentist, is Invisalign, and that's just a clear trays. And he usually doesn't recommend it to children because that's 100% dependent on how much the patient wears it. And we also do metal or porcelain, as you guys know. Porcelain, it really depends on the doctor, what they say. Dr. Navarrete says that it does delay treatment a little bit because it's more prone to breakage, but Dr. Chen says that for him, he doesn't see much difference in the time it takes for patients to complete treatment. But both of them, they usually only recommend that for adults and only on the top. On the bottom are 3 different types of brackets. We have the first one, which is for canines and premolars with the hooks. Second one is the ceramics, and the third one is just the regular anterior brackets. So at their second appointment, we do their records, and that includes the impression, the pano, and some pictures. So first, to take the impression, we get a tray and then we trial fit it into the patient, make sure that all their teeth are covered in the tray, it's not too big for them, they're not uncomfortable. And then after, we get a mixing bowl and the spatula, we measure out the water and the alginate material, and then we'll rapidly mix the mixture by pressing against the wall of the bowl to prevent any bubbles from coming. And then finally, we'll load it into the tray and take the impression of the patient's teeth by pressing on to their teeth. And then to remove, we'll just use a rocky motion side to side to get rid of the vacuum effect and then take out the impression. And then we used to send out our impressions to Glidewell, and they used to give us a stone cast model. But now we're sending it to 3M, and they do digital models. It'll just look like the picture up there. And from that, the doctor can go on the computer, make measurements on the computer, and make notes on that as well. So the first thing that they take is a pano. It's just a 2D X-ray of both the upper and lower jaw. And this is to help see what teeth are developing and things like that. So it's a panel of a child. You can see he has a lot of his baby teeth still, and then his adult teeth are coming in. And then we also do pictures, intraoral and extraoral pictures for the teeth and of their face. We take 2 of them relaxed of their profile and then straight on, another one of their right smile. And then we also take pictures inside of their arches and their biting, and that's to help with molar classification and to keep for our records to see how the patient's teeth were before they started treatment. And after, some additional things that we need from the patient, and they may not necessarily get it at our office, is the ceph tracing, which is a more specialized x-ray of the side profile of the patient. It shows the bone structures, the teeth, and soft tissues as well, so it really helps the orthodontist see how the bone structure will change throughout the treatment, and also gives them a better idea of whether they should recommend extractions and how that will change their bone structure as well. And also they need to get cavity clearance from their general dentist saying that they had a recent cleaning and a recent exam with x-rays, and this is just to make sure that everything is okay and there's not any underlying problems that we need to treat before they get braces. Okay, so now we go to bonding, a little video. Okay, just goes through the steps. So first the tractor is inserted to try to isolate the area. You really want to watch out for saliva because that can mess up with bonding. And then next they're going to polish the teeth to clean the outside of it. This is different from the prophy paste that we use. This is just pumice without any fluoride or anything like that. Now they're putting on the etchants. All rinse and dry. And then apply a primer on the tooth. And then finally the adhesive will go on the back of the bracket. And then either the assistant or the orthodontist can place it on the tooth. And then the orthodontist will check the size of the brackets for extra adhesive, and then he'll check the alignment of the bracket to make sure everything is okay. And then after everything, he makes sure it's okay, then the assistant will go ahead and light cure all of the brackets. So once they put on all the brackets, they'll do a quick sweep of the entire arch for about 20 seconds for the entire arch. And that helps to set the brackets initially, and then afterwards they'll go tooth by tooth and cure it for 20 seconds each. And then afterwards the assistant will use an Explorer or something else to make sure the brackets are properly secure and not moving. And usually they'll do one arch at a time. And then next, some patients get something called a molar band, and this is a band that goes on the back molars. Usually our younger patients do get this, and our older patients get the bondable tubes. This is for the molars on the very end of both the top and the bottom, and it's the part that you insert the wire in. The first one is just a standard molar band. And the second one is a molar band with a headgear tube, so you can see there's an extra little hole in there, and that's where the headgear, it attaches and goes in. And then, so the molar band, it actually fits around the molar of the tooth, but the bondable tube is just like a bracket where you just bond it on the very last tooth. And bondable tubes are a little easier to clean, so orthodontists tend to use that a lot, but molar bands if they need more aggressive treatment or things like that. If the orthodontist would like to use molar bands, then we have to place something called separators a week before, and they can either be rubber or steel. The ones in this video are rubber separators. They're just placed in between the back molars to open the contacts, so later when the orthodontist goes to place the molar bands, they're not as hard to fit in. So this is a video, they'll stretch out the separator, and then they'll place it in between the tooth on either side. And then later, a week later, when they come back in there for their appointment, the orthodontist will remove that with an explorer, and then they'll be able to place a molar band where the spaces are created. So it'll look like that. Okay, and for some patients, they have a really deep overbite. So to correct that, we do something called occlusal bonding. And this, we use something called blue transbond, and basically the steps are the same. We clean the area, we put adjuvant, primer, rinse, isolate very well, and then after, you can see the little blue bonding agent. We usually use that for banding, for molar bands, but we can also use it for occlusal bonding as well. We place it on the back molars, so when the patient bites down, they'll bite down on the occlusal bonding and instead of their teeth, so it opens up their bite a little bit. So if they have brackets on the front that they be hitting, it opens up their bite so they won't hit the brackets. And the reason why we use a blue bonding is so when we remove it later, we won't remove any of the enamel, and it's easier for the orthodontist to see. But of course, if we don't have that, we can also do it with the regular composite. Okay. So after all the brackets are set, the orthodontist will place the wire. Sometimes he or she will wait a month just to let everything settle before they put the wire on the patient, because that puts more stress on the teeth. And sometimes the orthodontist leaves the wire out so the patient can go get some extractions before their next appointment. So the type of wire will be chosen by the orthodontist. There's a couple of different types. There's one called a nitinol, it's shortened as NiTi, and a different kind called stainless steel. The NiTi wire is also called the magic wire. No matter how you bend it, it'll just go back to its original shape. So it's good for initial, the first couple appointments, because it is thinner and more flexible than the stainless steel. Okay, so if it's a new patient, you want to trim the wire to just roughly the approximate length, so when you place it into the patient's mouth, it's not poking them in the back, it's not extremely uncomfortable for them. If this is their second or third or next appointment, then you can use their old wire as reference to cut it to about the same length. When you do cut it, you want to cut it at an angle, such as this picture. Cut it at a diagonal angle, so when you enter it into these tubes, they're easier for them to slide in. Then if you cut it straight across, then it would make like a rectangular or a square shape, and it'd be harder for it to go into the round tubes. There's different markings on the front of the wires for the lower and the upper. They're going to be located on the very front. And for the lower, it's just one marking, and then for the upper, it's going to be 3 markings. These markings are used to check for the midline. When you place it on the patient, you want to make sure that this goes exactly in the midline where it should be, not where their midline is now. After we place the wires in, we check the center, and then we can secure the arch wire. There's also a couple of different ways to do that as well. When you secure the arch wire, you always want to start from the middle and then go towards the canines and the premolars, just so the center isn't moved if you try to start from the back molars. We have rubber ligature ties, stainless steel ties, and power chains. The rubber ligature ties are the most common ties that we use. They're the color ties that you see on kids a lot. To place it, you just use the Matthew plier and pull it around the wings of the bracket. So after the wire is put in, you check the center. And this animation is a little misleading, but you would hook it onto this corner first and then go around to each corner until all 4 are secure.